Please start. We are live.
Mandeep, please start.
వాళ్ళు మాట్లాడేది వినబడాలి కదా నాకు ఫస్ట్. వాళ్ళు మాట్లాడేది వినబడట్లేదు. దే ఆర్ అంటే డిస్కసింగ్ సంథింగ్. మరి ఇంకేముంది, బాగానే ఉంది, మంచిగా ఉంది. ఫుల్ పెట్టా వీడియో. ఐ డోంట్ అండర్స్టాండ్. వీళ్ళది రావటం లేదు.
Mandeep, we are live. Can we start?
ఎవరు లేరు. అవునవును, ఇప్పుడు అది ఓపెన్ అయింది. ఐ కెన్ సీ ద వీడియోస్ బట్ దేర్ ఇస్ నో సౌండ్ ఎట్ ఆల్. ఓకే ఓకే సరే.
Aman, can you please mute Dr. Rajalingam?
ఓకే, అది కూడా చేస్తాను. బాయ్ బాయ్.
Season meeting.
Mandeep, we cannot hear you, please.
She's not audible at all.
Mandeep, you are not audible.
So probably while we fix, I will start the event. Then I welcome you all to the FICCI East South India Conclave Spotlight on Visually Impaired in the wake of COVID-19. COVID-19 has had a tremendous impact on eye care delivery across the globe, and hence, not surprisingly, aftermath of COVID-19 virus has made a significant impact on ophthalmology in India as well. Since the lockdown happened, patients have been willing to postpone their appointments instead of taking the unnecessary risk of contacting the virus at clinics or the hospitals. This pandemic and its consequent restrictions also bring immense financial, logistic, and psychological challenges for the patients. They face difficulty in maintaining all the rules of social distancing in a public setting and may have difficulty in wearing masks, may fear being prosecuted for revealing their travel history, and fear during the mandatory questionnaire at the hospital. All these factors make the simple visit to the hospital very tedious unless absolutely mandated. Teleophthalmology has been picking up and bridging the gap, although in very small part. For poor patients in remote areas with no phone, this follow-up is also not possible. In remote areas, rural medicine supply for cataract surgery patients has dried up. COVID-19 pandemic rages in the country, visual impairment could turn out to be one of the biggest challenges facing healthcare providers as eye-related procedures take a backseat. This is leading to the progression of severity of the condition and blindness, which are preventable with timely diagnosis and treatment. In fact, experts predict a sharp influx in the number of blind people in India owing to delayed or discontinued treatment. Considering the necessity of addressing the concerns related to vision care in India, this online reach assumes a great significance. I'm happy that we have such eminent experts from this domain today with us to share their thoughts and perspectives. Today, as part of this conclave, we get an opportunity to special talks from senior representatives of prestigious organizations and doctors working in the domain of eye health. This will be followed up by panel discussions of the experts on patient-physician collaboration to manage eye disorders in COVID-19 and private-public partnership to achieve Vision 2020 goal. So without taking
now I
much
got
time,
it.
I
You
would like
can,
to invite
but I'm
Dr.
unable to
Malika
hear
Goyal,
any voice. Voice is not there.
consultant, ophthalmology, Apollo Hospitals, Hyderabad,
I
for
did the
delivering
same
the
thing.
welcome address to the August gathering today. Over to you, Dr. Malika.
Good afternoon and namaskar to everyone. Sri
What
Syed
happened
Ali
to
Murtaza
this?
Rizvi, Principal Secretary, Health, Government of Telangana. Dr. Rajini, Joint Director, Officer for Blindness Control Program, Department of Health and Family Welfare, Government of Karnataka. Expert speakers, eminent dignitaries from states, doctors, healthcare officials, patient and patient advocates. It gives me immense pleasure to welcome you to this South India Conclave Spotlight on Visually Impaired in the wake of COVID-19, organized by the Federation of Indian Chambers of Commerce and Industries, also called FICCI. I'm thankful to Novartis India. Dr. Rajalingam, can you mute yourself? I'm thankful to Novartis India, Vision 2020, International Agency for the Prevention of Blindness, IAPB, and the Retina Society of India for supporting this initiative by FICCI.
Aman, please mute Rajalingam, doctor.
India was the first country to launch the...
Now I'm able to hear it. Okay, just, yeah. We'll see. Right, thank you.
Dr. Rajalingam, I would request you to please mute yourself.
Okay.
Please go on, Dr. Malika.
Okay. I'm thankful to Novartis India, Vision 2020, International Agency for the Prevention of Blindness, and the Retina Society of India for supporting this initiative by FICCI. India was the first country to launch the National Program for Control of Blindness in 1976 with the goal to achieve reduce blindness prevalence to 0.3% by the year 2020. And the Ministry of Health and Family Welfare must be complimented for the fact that NPCB has been one of the most successful programs. However, despite decades of efforts, the survey data of October 2019 state that the estimated prevalence of blindness still stands at about 2% and moderate to severe visual impairment at about 12%. So the target was 0.3% and we are still at 2%. FICCI has been undertaking various endeavors towards increasing the focus on health promotion, prevention, screening, early intervention, and improving the quality, safety, performance, and accountability of various health services. FICCI is in partnership with government on accelerating the achievement of healthcare objectives across various disease areas and help enhance outcomes through multi-stakeholder deliberations. While government programs clearly underline the importance of universal prevention of blindness, these objectives cannot be achieved without the participation of private practitioners and voluntary organizations. FICCI has organized a similarly titled National Conclave on August 14 this year, which brought together on one platform members of parliament, policymakers, government doctors, heads of leading eye associations and societies, patient advocates, and healthcare finance experts. That program was hugely successful and highlighted that a change in health-seeking behavior during the COVID pandemic leading to delay in seeking appropriate treatment might push patients towards visual impairment. And in fact, visual loss could turn out to be one of the biggest challenges facing healthcare providers from this pandemic. So following this national conclave, FICCI is organizing region-wise conclaves on visual impairment in East, South, West, and North India, The first of this series, the East India Conclave, was held on September 22 this year, covering the states of Assam, West Bengal, and Odisha. The second in series, the South India webinar, is being held today, covering the states of Andhra Pradesh, Telangana, and Karnataka. The regional conclaves are being organized with the objective to discuss some of the challenges encountered, government approach, newer advances in eye care technology, and increase patient awareness during the COVID pandemic. I extend my compliments to FICCI for organizing this regional conclave and getting the focus back on patients during this pandemic. I'm confident that the eminent panel of speakers and experts will discuss most of the critical issues and immensely benefit the participants and patients at large. My best wishes for the success of the program, and I look forward to more such dialogue to achieve the goal of universal prevention of blindness. Thank you.
Thank you, Dr. Malika, for the welcome address. A request Dr. Rajni, Joint Director, Officer for Blindness Control Program, Department of Health and Family Welfare, Government of Karnataka, to please deliver. Ma'am, would request. Yeah, thank you.
Good afternoon, everybody. Yeah, first of all, let me thank the organizers for giving us an opportunity, the state of Karnataka, to speak on this a prestigious platform about National Program for Prevention and Control of Blindness and Visual Impairment. It's my pleasure to address this gathering where many dignitaries have joined here, and I'm also very privileged and happy to speak among the various eminent ophthalmologists who are in this platform. So first of all, already the burden of blindness globally and in India has been talked about. About 90% of the world's visually impaired people, they live in the low socioeconomic status. And 82% of the people, they live with blindness and who are above 50 years. The goal of program has been mentioned already to reduce the prevalence rate from 1.49% to 0.3% by 2020. There is a lot that needs to be done. And the program of National Control of Prevention of Blindness and Visual Impairment, which has been successfully running in all the states with the support of National Health Mission, now it has come to a grinding halt because of this COVID-19. Challenges have been mentioned very well by Mrs. Swati. Like conducting camps has been a challenge. Conducting cataract surgeries has been a challenge. Eye collection is a challenge when a lot of COVID deaths are there. School eye screening is a challenge. Trainings, of course, with this virtual platform, other than that, physical trainings are not happening. Basically, in ophthalmology practice, what is required is this based training, which is really not happening because of COVID-19. And the regional ophthalmology centers, most of the ophthalmology centers which were conducting surgeries have been converted into COVID hospitals also. So that is again a drawback for the government. Screening of elderly, the diabetics and hypertensives for any retinopathy is again a constraint. Since most of the government centers are functioning as COVID centers, government by itself is not able to handle this huge challenge, and that the ophthalmology program has come to almost a grinding halt. So what is that needs to be done? We definitely agree that vision is one of the most cherished sensory organ. Sarvendriyanam nayanam pradhanam. Without eye, anybody would be really handicapped. Even today, as a government official, I would say that infection, malnutrition, vitamin A deficiency, they are posing problems and adding to the causes of childhood blindness. So on the one hand is the childhood blindness, and the other hand is the cataract, age-related cataract. So in this endeavor, where we need to achieve eye health care, the universal eye care for all, really needs hands, the NGOs, the private practitioners, and FICCI who can join with government in achieving this endeavor. COVID has posed a huge challenge, but happy to note that the private people have been able to conduct the surgeries And that is where, to some extent, we have been able to address the problem of blindness. So strategies of NPCB, it includes involving private sector, thus giving the program the character of a movement to establish partnership institutions. This is where government would look at to join hands with NGOs and other like-minded private partners to achieve the goal of universal healthcare. To talk of Karnataka as a whole, we have been able to issue the guidelines how safely and effectively the ophthalmology practice can be done at our health centers, joining hands with the NGOs and other private players after having taken the opinion from the technical advisory committee to ensure distancing and prevention of infection and all those things. And the other initiative what has been done is we have started the mobile ophthalmology units. Various districts have these mobile ophthalmology units. So we have now encouraged to conduct the outreach camps using these mobile ophthalmology units, ensuring that limited number of permissible people organize themselves in the camps. The people are picked and then they are moved for surgery camps. And the third one is the one initiative what Karnataka government has done is we have one Jiva Sarthakate, a module where the organs, the donated organs, the donors are registered in this Jiva Sarthakate. So similarly, we have initiated this process of including eye donation in this so that the donor who wishes to pledge their eye will be registered in this Jiva Sarthakate and they will be given a certificate of appreciation. So this is one initiative which has been taken up. And the other things we are trying to push on regarding the practice of ophthalmology, how best it could be carried out in the state. We have initiated diabetic retinopathy project at 2 of our districts. And most important aspect which has taken out is the tele-ophthalmology unit. So at least through this, we have able to initiate to address the retinopathies related to diabetes or hypertension. Of course, retinopathy of prematurity screening is happening with in association with Narayana Netralaya. So these are some of the initiatives. We'll forward to join more hands with the private players to make our state corneal blindness backlog free. We have started the eye collection centers also in all our district hospitals, and until now 19 centers have been opened. So I take this opportunity, this platform, to request all the private players to join hands with the government, with whichever state it is, whether it's Karnataka, Andhra, Telangana, whatever it is. We request them to ensure their participation with us so that we are able to ensure that each district becomes preventable blindness free. Thank you so much. Thanks for the opportunity.
Thank you, Dr. Rajni, for this address and sharing your perspective. May I now call upon Dr. Tara Prasad Das ji for sharing his address on the technology for last mile eye care in India. Dr. Tara Prasad is Chairman Universal Eye Health Program, Government of Odisha. He's also Vice Chair, LV Prasad Eye Institute. He's also the Regional Chair for Southeast Asia International Agency for Prevention of Blindness, IAPB. IAPB is an alliance of civil society organizations, private sector, and professional bodies promoting eye health through advocacy, knowledge, and partnerships. Over to you, Dr. Das.
Thank you, Mandeep ji. Swati ji, can you show my slides? Because I depend on you on the technology part of it.
Yes, we are putting it up.
Good afternoon, everybody, and thanks for wonderful introduction, Malika, followed by from Karnataka government officers. Is it a full screen? All right. So I will talking about all these meetings from national to east zone. You're talking about we heard that for the COVID-19 infection, which is continuing and might continue in my knowledge for a few more months in India at least. Patients are not able to come. So are we ready to reach the patients closer, if not at home, closer to the, in that context, I will talk about it. Next slide, please. This has gone to last slide. Sorry. Yeah. This is the blindness profile which Malika spoke about, that last year, October, when the Government of India published this data, that we have got 12.9% of blindness and 62 million people of visual impairment. We are not very far from the global blindness of 14.2%. Next slide, please. Just few days ago on October 8th, the World Sight Day, this was published data, the latest data for the world. It shows that India in the Southeast Asia or South Asia is highly prevalent of blindness, along with Indonesia, Bangladesh, and Nepal. Next slide, please. Next slide, please. And the data between 2015, the last publication 2017 by the vision loss expert group, and now it shows that the blindness magnitude actually decreased by 1.5% from 14.2 to 12.7 in the world, not India. But the moderate to severe visual impairment has increased by another 1.5%, but that is the magnitude. Look at the total number. Actual number increased from 36 million to 43 million, 217 million to 95 million, and total vision loss increased by from 253 to 338 million, which is 19, 30, 36 and 33% increase in what it was before. And why it is so? Next slide, please. And that's mostly because, next slide, please, because of the huge rise in the population. So this blindness profile is increasing all kinds of blindness, mild, moderate, severe, and the female, unfortunately, are more affected than the male. Next slide, please. And these two squares shows about where we are, South Asia, where India is, and Southeast Asia, where we also work, that the blood blindness and visual impairment higher compared to many other regions of the world. Next slide, please. Next slide. Well, technological, I'm not able to share the screen. This shows the world blindness profile and where we are, that in South Asia or India, Nepal, Bhutan, Bangladesh as South Asia, called South Asia in the WHO region. And South Asia has got near vision impairment 167 million. Somehow or other, so we grow near vision for a long time, but today, when people are living longer and there is a newer technology like a mobile phones, require good near vision also. So near vision included in this newer data analysis, 167 million near vision, then the mild, moderate and blind people are from 12 to 60 million or 96 million. Next slide, please. And this is not going to decrease, unfortunately, till this graph shows up to 2050. This blindness in any form from moderate blindness will continue to increase 2050. Next slide, please. And that mostly because of the, next slide, because the huge population rise. Today, by 2030, we will have a 16.5% people in the world will have a 60 plus, and by 2050, 21% or 1 in 5 will have actually will be above the age of 60. Because of longer longevity, we are not going to reduce the blindness the absolute number. However, because of the work by different international national organizations, the magnitude of blindness might reduce in future. Next slide, please. And also, as I told you, the women are more affected, and the 12 in general 12% times more affected, 8% time more likely to be blind, 50% MSBI, 12% more likely to mild vision, and similarly 11% for near vision. That means, unfortunately, the data till now in the world is not talked about the marginalized people, poor people, or tribal people like we see in India. Supposing Indian survey done for those kind of work, then we'll see that there's a huge inequality between the marginalized and non-marginalized people in the country. Next slide, please. This is the data from last year, Government of India data. You say that by increasing age, there is a 184% increase in the incidence of cataract. 200% increase in diabetes. So that is why, so we have to be more careful about the people who are older, 50 plus or 60 plus. Next slide, please. One of the reasons why it's happening all over the world, particularly India, is that in India, we are emerging from a low economy to a moderate or higher economic status. In that situation, infection, communicable disease goes down, life diseases, lifestyle diseases, particularly like diabetes, increases. So we are in the middle of the transition. In this transition, we're likely to see more increase in a number of blind people, and also included, in addition to cataract and refractive, included in our diabetes, glaucoma, and other diseases. So we are not going to see reduced blindness in next 30 years to come. Next slide, please. The idea of universal health coverage we just now heard about is not a great new idea, absolutely, because 1978, more than 40 years ago, we heard about it when WHO and UNICEF convened the meeting in Alma-Ata, and then followed by reconfirmed the idea in 40 years later in 2018 Astana. In between 2015, the World Health Organization comes out the idea of a sustainable development goal, 17 goals, 169 parameters to improve the health, and health was in a goal number 3. Next slide, please. This happened because this is required because our entire coverage of of healthcare is not uniform. We still need a population to cover. That means you're not covered entire population. There's a huge service gap between what we do and what you have not done. And finally, there is a huge catastrophic financial restriction. That means we have to cover all the 3 dimensions of population coverage, service coverage, and reducing the risk of financial stress. Next slide, please. In 1978, when Alma-Ata was convened, then USSR, we talked about the primary care. Primary care is the one that provides appropriate, accessible, and affordable care that meets patients' eye care needs in a comprehensive and competent manner. In 2018, this was renamed as Universal Health Coverage. It includes equity, equality, quality, and protection from financial risk. And the Sustainable Development Goals, they talk about goal number 3 in SDG for 2030, exclusively focus on health and promotion of lives. But the important thing is the well-being, just not the cure the disease, but well-being for all ages. Next slide, please. Three important aspects of the universal health coverage: access to care, access to the care when and where they need it, not where you are, but then where the patient actually is. Then 2 is that without any huge financial hardship. Next slide, please. To that extent, last year, World Sight Day 2019, WHO published this wonderful report, very voluminous report called World Report on Vision. Next slide, please. And this report talks about, next slide, talks about something called integrated people-centered eye care, where people are empowered and reoriented model of care, coordinated between the sector, just not stay in the eye, but current entire sector of the health, and finally create an environment which will enable both the provider and the receiver. Next slide, please. In that context, why they should have divided the eye care service delivery into 4 models, from 4 tiers, from community to primary to secondary to tertiary, and that the slide on the right side shows about that how this is accessible, how this is acceptable, how this is available, and how it can be referred to a higher center when required to. Next slide, please. We at LB Prasad also designed the similar thing several years ago, almost 2 decades ago, which WHO recently recognized it. That however, we added one more layer in the top, which is shown in the red, layer number 5, and that we show that those are in a populous country, and our publication says that, like India, Myanmar, Nepal, Thailand, Indonesia, and so on in our region, is they must have one more layer, because 4 layer is not enough to cover the entire population. Next slide, please. Applying that idea to our own care, we have got over 210 centers across our own. LB Prasad has got a community to primary, secondary, tertiary, and center of excellence in Hyderabad. Next slide, please. The Government of India a couple of years ago talked about a health and wellness center, with exactly what Aries Prasad talked many years ago, and WHO spoke last year. If you divide the Indian population 1.3 billion people, and by the population divide of 5,000 people for one health well and 50 million people for advanced center, then you require in the country numbers shown there, when require 270,000 health wellness center catering to people of 5,000 people, etc. And similarly, number goes down to 27 advanced tertiary center in the country. Next slide, please. Despite all the effort, we look at the region. This is publication of WHO last year. In universal health coverage, India is 61% of the 100. We are above certainly Nepal, Bangladesh, Myanmar, and Timor-Leste, but behind many countries like Thailand, Bhutan, Maldives, Sri Lanka, and Indonesia. So when will we rise there? Next, please. Next slide, please. What we need today is, not because of COVID alone, but require a comprehensive eye care that is always quality driven, delivered at the close to the doorstep, and also a continuity of care. We heard about the outreach program. Outreach program is good, but the 1940 it was good, maybe not in 2020 or 2021 anymore. Can you go closer to the patient? That is what health wellness center, that is what primary care is. Next slide, please. We saw a reverse migration of patients. That's why talking to in the morning, in the afternoon, talking to Dr. Goel, that we saw that between September 2019, LV Prasad, the entire system, and 2019 September of LV Prasad system, we say that there is a OPD, there is a 7% rise in the vision centers and secondary center, and 10% reduction in the metro center like Hyderabad. Similarly, in a secondary center, surgery has risen by 4%, a decrease by 7% in metro center, which means that people, out of fear or not necessary maybe, they will not future travel to the bigger center, and they will look for their own opportunity closer to the doorstep. So this is the time, COVID and no COVID, we should design our technique and technology to go there. Next slide, please. And that I call the last mile eye care. So are we ready? For the last mile eye care, we need high-tech techniques. We need high-touch instruments. We require small, digital, and portable, so that people can go to the house and get the examination done, or patient can come nearest possible center, not necessarily large, big centers in big metro cities. Next slide, please. Looks to me that we are ready. We heard about that Government of India has already legalized the tele-ophthalmology. We at Prasad had developed something like Connect Care. Connect Care is people both by audio and video, and is much more useful than doing only audio connection. Next slide, please. And we have the basic instrument for eye care is slit lamp, and we have got developed a system called a drone slit lamp, where a patient need not be, and the health provider need not be near the patient. The slit lamp somewhere else, like in the top left, and the viewer can be somewhere in the bottom left, and can examine the patient exactly, and can advise by viewing because sometimes to examine the eye, without that we cannot examine. Today in our own system, we have 16 of them installed, ranges from 37 to 883 kilometers, and we're profiting a lot from this. Next slide, please. This is more important for a COVID time. We also have developed, and others have developed, screening devices which can examine the refractive error and which can be generated a prescription through a teleconsultation. Next slide, please. We have now developed in the country, intraocular lenses which can be implanted into the eye without depending on the multinational company technology. And remember that in the last year, when we have operated almost 7 million cataract surgery, 89% of them actually received intraocular lenses made in India. Next slide, please. We also have for a glaucoma evaluation, we have a system called order of magnitude, which can be fitted into a patient's eye anywhere, at home or on a small clinics, where you can examine the visual field and then direct for the YAG laser, for the angle closure glaucoma treatment in a hospital. Next slide, please. And finally, we have all the devices for retinal examination on the left side, all the cameras. or in either phone base or a tabletop. And for pediatric, like we heard about Kid ROP from Nethralaya, from Narayan Nethralaya, they're using this. That's what they're using. And in the right side is the slit lamp delivery system for laser made in India, which is much cheaper and readily available. Next slide, please. With this, all the systems available, this year's World Sight Day slogan was "Hope in Sight." Despite our COVID and future similar pandemic situations, we have the technique and technology today where you can go nearer to the patient instead of patient always coming to you, and that should be our new goal. Next slide, please. Today is a former President Dr. Kalam's birthday. And I'm sure he must be smiling from heaven that, and he would have loved to see that India becomes self-reliant on technique and technology. Thank you very much.
Thank you, Dr. Das, for the address. May I now invite Sri Chanakya Mishra ji, Business Head, Novartis India Limited, for delivering the trigger talk on Netra Nirbhar during COVID times. Over to you, Chanakya ji.
Good afternoon and greetings. Greetings to Dr. Rajni, Joint Director, Office for Blindness Control Program, Department of Health and Family Welfare, Government of Karnataka, Dr. Tara Prasad Das, Vice Chair, LB Prasad Eye Institute, and Regional Chair, Southeast Asia Region, International Agency for Prevention of Blindness. The moderator for panel discussion, Dr. Shri Bhargav Natesh, Consultant VR Surgery, Director Netra Eye Hospital, Bangalore. Dr. Malika Goyal, Senior Consultant Ophthalmology, Apollo Hospitals, Hyderabad. Mr. Aries Rizvi, Senior Vice President and Health Risk Consulting Leader, Anviti. Eminent panelists and healthcare professionals, media persons, patient advocates, and most importantly, all our distinguished participants who have joined us for this relevant and extremely critical discussion. At the outset, the noteworthy work that government has done over several decades to bring to the fore eye health and preventable blindness has been indeed very inspirational. We heard Dr. Rajni earlier today about the great initiatives of the mobile Ophtha units during COVID and the Jeevan Sarthak campaigns. Today, as we juxtapose this priority to the current unprecedented time, the subject becomes even more relevant. It is one way or the other impacting each one of us, all gathered here today. So what does coronavirus mean for the visually impaired? What does coronavirus mean for those at risk of vision deterioration due to delayed diagnosis? I always get very inspired whenever I hear about the initiatives about the last mile eye care told by Dr. Tara Prasad. It is very impressive to see how we can reach patients at this point of time, wherever they are, and we can take the hospital to them even in the rural areas. But at the same breath, I also want to highlight the fear this pandemic has brought, not only in the rural areas, but at the very heart of our cities, our metros. Let me confess, for me and for my family, and the most people I know, the fear of this unknown has been far more daunting than any other known evils. We fear contacting this virus so much that we ignore blatant symptoms because we don't want to step out of our homes. We are scared of visiting a physician, miss our appointments and treatment regime, and this is even more detrimental when it comes to our eyes. We all have elder parents or relatives living alone. We have all heard stories about them during this period of time. So let me tell you my story. My paternal aunt is medically diagnosed with age-related macular degeneration, a degenerative retinal disease. She lives in Nagpur and along with her 79-year-old husband. Their children, my first cousins, are based in the US. Recently, my aunt took a fall leading to minor injuries, but this unfurled major revelations. On inquiring how and where she fell, she told us she fell on the staircase and managed to hold on to the side railing, which essentially saved her from rolling down. Now, one can say that at 74, it was perhaps old age that made her lose her balance. On probing further, she mentioned she couldn't judge the height of a stair. Mind you, a staircase inside her home that she has been climbing up and down for over 4 decades. She underestimated its height and she was losing the sense of depth in her vision. Further on, we realized that she had stopped watching television since it was not very clear, She was getting confused with medicine labels, and that their home nurse was helping her with that. When we asked her when she got her treatment for AMD, then we understood the problem. She had missed 3 visits to the retina specialist. She chose to be quiet about it since she feared that going to the hospital due to coronavirus, and she knew that her children may pester her for going and getting that treatment. This is what is very sad and scary. Every day we see elderly in our families are getting more and more anxious. Many of them are living alone with an equally elderly spouse, consciously or subconsciously, posed with the existential questions like, is this the end of life? Will I ever meet my children? And so on and so forth. When they hear about their vulnerabilities to the pandemic, it is very, very heart wrenching. While I must mention that my cousins have built a very able ecosystem for my aunt and uncle and call them up frequently, they never really ask the question, "Theek se dikh raha hai na?" or "Is your vision fine? Are you able to see clearly?" So, an important question that stares us in the face is whether there is a collateral damage that we are overlooking in this pandemic. In order to be Atmanirbhar, we must be Netranirbhar. That means we should be able to be dependable on our own eyes. India is home to one of the largest and growing geriatric population, with nearly 35% of them living with some or the other form of visual impairment. We have a third of the world's blind population. Cataract accounts for around 31% of blindness, with an estimated prevalence of 125 million. We also have 12 million glaucoma patients, and as we well know, glaucoma is a leading cause of irreversible blindness. Owing to low disease awareness and associated asymptomatic nature of the disease, the diagnosis rate of glaucoma is as low as 10%. Essentially, by the time a patient is diagnosed with glaucoma, 40% of damage is already done. And so imagine what is happening during this COVID pandemic. It is important to remember that our elderly are vulnerable both physically and psychologically. Their fear, anxiety, and apprehension need to be addressed, and perhaps regular check-ins by family members or caregivers need include decision and discussions around vision. Unfortunately, the concern does not stop at our elderly. We have the second largest diabetic population in the world, 77 million to be precise. And Dr. Tara Prasad Das showed how in a country like India, this is only going to increase. It has become the 5th leading cause of blindness across the globe. A diabetic patient is 25 times more vulnerable towards the possibility of getting blind as compared to a healthy individual. Diabetic retinopathy alone affects nearly 18% of the diabetic population in India. And we can see how more number of diabetic retinopathy patients are now happening because of this COVID lockdown. Startling statistics indeed, but most of these are from before COVID-19 era. A recent paper in the Indian Journal of Ophthalmology bases a survey amongst ophthalmologists in India during the lockdown highlighted that 72.5% of the respondents of this survey were not seeing any patients due to lockdown. Even as we gradually are opening up the lockdown, healthcare professionals are getting back to their clinics, but patients are not getting back. They are delaying their visits. This may lead to worsening of their eye conditions and may eventually lead to irreversible loss of vision. If we don't act now, it is difficult to really fathom what these statistics will look like for India for years to come. At Novartis, we are committed to reimagine medicine to improve and extend people's life. We use innovative science and technology to address some of the society's most challenging healthcare issues. We discover and develop breakthrough treatments and find new ways to deliver them to as many people as possible. During these unprecedented times, in collaboration with patient organization and industry association, we are bolstering patient education and disease awareness initiatives for those who are visually impaired. The fact that we are gathered here today lays concrete the common purpose that all of us share. We laud the government to be one of the torch bearers in prioritizing prevention of blindness. As has been earlier told, that preventable blindness is something we should definitely prevent. Given that the goal is to bring down the prevalence of blindness to 0.3% in 2020, it is imperative that all stakeholders embody the force required to make the states Netranirbhar, with early diagnosis and timely treatment to take the message around that eye health is important for the masses. We look up to the noble government of various states to take it forward and become the trusted voice of the nation. We at Novartis are committed to this purpose and are happy to support as knowledge partners for this endeavor. Thank you so much.
Thank you, Chanakya. We now move to the discussion. Patient-physician collaboration to manage eye disorders in COVID scenario. This panel discussion will be moderated by Dr. Sri Bhargav Natesh, Director, Netra Eye Hospital, Bangalore. Dr. Sri Bhargav Natesh is MBBS from Mysore Medical College. He has completed his post-graduation from Shell Eye Hospital, CMC, Vellore, and Retina Fellowship from Shankara Nethralaya. He has done Ocular Oncology Fellowship from New York Eye and Ear Infirmary. He is presently the Director of Netra Eye Hospital and also the CMO for Drishti Group of Hospitals. Over to you, Dr. Bhargav.
Thanks, Swanti. Thanks for the kind introduction. I would like to thank FICCI, Novartis, IAPB Vision 2020, and Apollo Hospitals for arranging this panel discussion, which brings out the challenges and also some amount of solutions to the present problem that we are seeing. I would like to skip the introduction because I think we have covered it well enough, and I would like to introduce the panelists for the first panel discussion. That's on patient-physician collaboration to manage eye disorders in COVID scenario. We have Dr. Rajalingam, who is the medical superintendent from prestigious Sarojini Devi Eye Hospital. He is the vice chairman for Telangana State Medical Council, honorary secretary to Telangana Ophthalmological Society. And we have Dr. Ratna, who is the CEO and co-founder of Dakshama Health and Education. She is the voice of these patients to the government, and she is the chair to the International Alliance of Patient Organization. We have Dr. Hemant Murthy with us, who is the medical director of Retinal Institute of Karnataka, Bangalore. Very eminent senior vitreoretinal surgeon and has many publications to his credit. We have Dr. Prasad Garg, who is a cornea and anti-segment surgeon, director and network head of Prasad Eye Hospital, Hyderabad. He is associated with Prasad for more than 2 decades and has received many research grants and has been a PI for many clinical trials and has many publications to his credit. And we have Dr. Sri Kumar, who is the assistant professor at REH Warangal. He's the medical director of iBank REH2. I'd like to hear his views on the donations that are happening. And he's the executive member of Hyderabad Ophthalmic Association. So I welcome all the panelists. And my first question would be to Dr. Ratna. She's in a very unique position to get the patient's perspective to us. So I would like to know from her, what is the challenges that actually patients are facing? We know that they are not seeking care, they're not able to consult, and what is their expectation from physicians and the system? Dr. Ratna, we are not able to hear you. We are not able to hear you.
Am I audible now?
Yeah, please go ahead. Yeah.
Okay, thank you. Thank you so much for asking the first question on this panel to me and bringing the patients to the forefront. So as you introduced me, I represent the patient voice both in India and globally, and we work on several range of issues. But in regards to today's discussion, I think the issues that bothering the patients, if I can use that word, are the same as for any other disease area. And one of the biggest is the fear. So there has been a lot of fear mongering, both because of misconceptions and myths that are floating around on social media and channels, and also the fear of the virus in itself. And that prevents people from going for their routine checkups and normal treatments that are compulsory and mandatory in some cases. And because of this fear, even if people know and understand the risks of discontinuing their treatment, they do not go to the hospitals because they feel that if they go there, then they might get the virus and that might be the end of their existence on this earth. The second is, of course, there have been so much of myths and misconceptions about the quality of treatments that are available in the hospitals, not really around retinal diseases or eye diseases as such, of treatment in general in both the public as well as the private hospitals, because they feel that wherever there are corona patients, the hospitals are extremely dirty and unhygienic, and therefore patients don't want to go. And there has been no counter campaign to help the patients to understand that for ophthalmology units, that's not true. And many a times, hospitals that actually give services to people with eye conditions are standalone and some of the most cleanest and hygienic hospitals. But that trust building has not happened. So people in their minds think of multi-speciality hospitals with a eye unit in some corner, which is as dirty as the rest of the hospital. So people don't want to go there. The third is, of course, for many patient groups, especially for the elderly, transport has been a problem, and therefore, even though they have their routine treatments that are listed in their diaries, they are not going because they are dependent on their children or some other care provider to transport them to the hospital, and nothing has been done to help them to overcome this challenge. And for many people, it has been a choice between whether they spend on healthcare or whether they spend on sustenance. So livelihoods and sustenance has become the forefront, and therefore healthcare has taken a backseat, and people are not able to come. Now, in terms of how can doctors help overcome this barrier, I think one of the biggest challenges in this pandemic has been to establish communication channels. We do know that telemedicine and telehealth has opened up these channels for many doctors, but for many, they are still struggling. So in many big hospitals, from what we have learned through our dialogues with the specialists, is that they do not have direct access to patient databases. It's the hospitals that have it. And therefore, for them, it is difficult to reach out directly to the patients. In the smaller hospitals, when we reach out to specialists, we find that they have the access to the patients, but they don't have the infrastructure, the wherewithal, or the mechanism to reach out to those patients and give them the services that they provide. So I think this fear has to be countered. Positive messages, and maybe the hospital associations and other big associations like the Vision 2020, etc., can do that. Good communication channels need to be established. So one-on-one outreach, use social media for positive messaging, and I already see that happening a lot on VRSI and other social media channels. Maybe give that a little more impetus using the patient groups and the physician groups and other groups that can then send out these positive messages, and encourage the patients to come back by giving them the message that if they don't take care of their eyes, then even though they survive, their quality of life is going to be very poor, and they will still be even more dependent on their caregivers than they are now. So I will say that in short, and maybe we can come back if we have time. Thank you.
Yeah, thanks, Dr. Ratna. Do you see that the same thing happening in other specialties also, or it's more related to only certain specific specialties?
Sir, it is happening across all specialties, but in the case of eye care, it is more complicated because many times, because of low vision, these people are already fearful of stepping out on their own. They can't drive, so they need some kind of transport support, even though they may have the financial wherewithal, but they would need some kind of support to reach a hospital. And the biggest fear, and especially because I work with patients with diabetic retinopathy and AMD, and these patients are usually a little more elderly, so they there is this huge fear amongst the population that if you are 50 plus and you have a comorbidity, then going to a hospital is like writing your death sentence, because you're sure to get the virus, and if you get the virus, then your chances of survival is very low. So because of this fear, and I see it in my family itself, the parents and other senior people don't want to go to the hospitals. And in case of lower eye vision, it becomes even more challenging because they need help and support for them to reach the hospitals and healthcare centers.
Right. Yeah. So thanks for that. My next question is to Dr. Rajalingam. He brings the experience from Sarojini Eye Hospital. Sir, I would like to know what are the practices that are employed in the COVID times to keep the patient safe. And as Dr. Ratna was elaborating, there is some necessity to kind of demonstrate adequate care
There's the loss of video. Hello.
Yeah, I think Dr. Bhargav has got disconnected, or he would be logging in back again in a short while.
Okay. Then can I continue with this?
Yes, please.
Yes, doctor.
Bhargav and the Novartis and FICCI for giving this opportunity for me. And actually, the patient population coming to the any government hospital is slightly different compared to the private hospitals. And the practice and implementation of the implementation is slightly different and laborious. And if you implement properly, and it is really a gratifying task. So during this COVID situation, we have followed the guidelines issued by the state and central government, as well as the All India Ophthalmological Society, and in especially in OPD practices. So we have thoroughly thermal screening was done, and no mask, no entry into the OPDs, and maintain the physical distance by drawing actually white lines on the floor throughout the OPD area and in wards, maintaining the hand hygiene by providing staff who are practicing in the Sarojini Devi hospital. We have provided N95 mask and PP kits, and all PP kits to all the healthcare workers, especially the doctors, PTs, and SRs, optometry students, and only double surgical mask to all fourth class employees, because there was some deficiency initially to providing the N95 masks. To avoid transmission during the state lab examination, we have restricted the talking of the patient and provided temporary face shield to the slit lamps as well as the operating microscope. And we have taken utmost care in wards as well as in operation theaters, stop OP measurement, non-contact photometry, and doing syringing also in OPD practices. So these are all measurements we have taken during the COVID period, especially in OPDs. Dr. Bhargav.
Yeah. Thank you, sir. Thanks for that. I would like to go to Dr. Hemant Murthy. He runs a private institute, has a huge OPD. Sir, I would like to know your experience of the similar thing, what is happening at the private setup. What precautions that can be taken, and what is the role of private institutions, doctors, and insurance agencies, and other stakeholders in getting the patient back to the hospital? And do you think we will be able to effectively counter the backlog that has been created? Maybe it's cataract or glaucoma or diabetic retinal eye diseases which require surgery, laser, etc. Do you think we should be able to cover the backlog in the next 6 to 8 months effectively?
Dr. Hemant, you are on mute.
Yeah. Thank you, Dr. Natesh. I know you've asked me a number of questions, so we have. I'll just go one by one. I think, in addition to what Dr. Rajalingam has been saying, that most of the hospitals are following the guidelines of the All India Institute, All India Medical Ophthalmic Association. So we all have the similar that we follow everywhere. So I think COVID has made us, little more aggressive in sanitization, cleanliness. So it has made us more aware of this. So I think this practice would probably continue. I don't think that's going to change. And we all do our fumigation of our OPD rooms, and we try to see how best we can keep everything safe for the patients. We have hand sanitizers in all rooms also in addition. So with all these safe measures, we have actually tried to approach the patients and make them aware through radio channels and the TV channels, and telling them that, it is safe for them to come because we have taken all the safety measures for them. But we all have to have the insurance and the other agencies which support the patients in their eye care to help them. You would know that these all these PPEs and all the measures that we have taken for protection cost a lot of money, but I think the insurance companies have no additional charges that are added on to what is built in. So we find that it's always an expenditure to us. In a small setup, I think doctors are facing a lot of financial stress because patients are less, and the measures that we adopt are quite a lot. So unless we have larger number of patients, we would probably have a problem coming on hand. There are some of these smaller setups have closed up because of this issue. The government agencies like the CGHs and all the other schemes that have come out, have not really supported private health sector to a large extent, because the reimbursement rates are so low that most of them have stopped, and they reimburse us the charges after about 6 months or more, which makes it very difficult for smaller establishments to continue working. So they should be actually proactive in such a situation wherein we are having a problem of blindness, which is now going to increase, that unless we see them also proactive in this, I think we'll always face a problem.
Yeah, thank you. Next to Dr. Prashant Garg. I want to know his experience of similar thing. What are the best practices that are put up at LVP Eye Hospital, and what cricket 2020? You think you're seeing more patient advanced stages of the disease?
I think the COVID fund, first of all, thank you very much for having me in this forum, which is kind of very timely. The COVID pandemic has put all of us in a very different situation than what we used to be in. We are facing a situation where not only we have to take care of safety of our team members, but provide a confidence to the patients that they are going to be safe when they seek healthcare. We observed this phenomena immediately after March 23rd, when the lockdown was imposed. Suddenly there was complete stop of patients coming to hospital. Slowly, as the time passed by, we started seeing a lot of emergency patients. The patients who had suffered sudden loss of vision because of injuries, because of retinal detachment, because of intraocular hemorrhages and other things. The patients who otherwise require a periodic check for their routine ailments still didn't return for the care. Now, what it clearly made out was the people were seeking healthcare only when it was absolutely necessary and for real emergency situations. Realizing that, we started creating a platform on which we started talking to our patient, which was in the form of telephonic communication to all our patients, that in case if they feel any problem, they can contact us. All the follow-up appointments that were scheduled during that time were contacted, and necessary advisors were given to them. We also started building on our tele-ophthalmology portal, which was using some form of video conference facility, and therefore that gave a lot of confidence to the patients. On our website, we started advertising what are the precautions we are taking. This had a huge impact. In the month of May, we not only were seeing most of the emergency patients, but we started seeing some of the patients who were suffering cataract, refractive errors and other. The difference was that these cataract patients probably were waiting for a longer period of time, and therefore the total number of or the patient presenting with advanced cataract was much, much higher than a usual cataract. That gave us a confidence that whatever measures are we putting are taking effect. We started talking to some of our social organizations. For example, I gave talk in the Rotary Club meeting as well as the roundtable group meetings, and tried to tell them that they can ask all the patients or the people who need eye care to give them the confidence that we are having all the systems in place and they can come to seek care. Realizing that we should be available all through, we also started our operations on Sunday, so that if the people feel that Sunday is the day that they can come, that we were available to provide care to them. Within the organization, we made sure that we not talk on these issues on social media, but we also exhibit. And therefore, there was a strict compliance and audit of all the processes that we talked about on our website. It comprises of monitoring PPEs by every employee, thermal screening, social distancing, both by employees as well as by patients, and the protocols that were put in place. These audits helped us significantly because that brings discipline even among employees, that they cannot take this pandemic and lightly, both for their own safety as well as ensuring that the patient get a perception that we are a safe organization. In the month of September, we were able to provide care to almost like 80 patients every day, and were able to reach the target of almost 120 surgeries. We are slowly gaining more and more confidence, not only about safety of our employees, but also safety of all the patients who are walking in. And I am very happy to share with you that we have not identified a single employee who has acquired infection while working in the organization, and not a single patient could be traced where the infection originated in the organization. We are calling all the patients who are undergoing surgery at 1 week to understand whether they are doing well or not. And based on that insight, we identified 7 patients who have got COVID, but their source of COVID infection was not hospital. It was outside the hospital. So all of these measures have in place a lot of confidence. What we have learned is that there is a need to continue to have a dialogue between society and healthcare provider if we need to bring the confidence that we have lost on account of COVID. I think the FICCI's effort in that direction is commendable. The same thing I'll appreciate Novartis' effort that they created this platform in which if the message goes out to community, I'm sure they will feel very confident in approaching healthcare services for their needs. Thank you very much.
Yeah. Thank you, sir. That was quite informative. I think we also, and a couple of the organizations that I know, also used screening of their patients to pick up the most difficult ones, or the ones which needed urgent care during the months of May and June. Of course, we had our share of false positives and false negatives, especially with retinal diseases. It becomes difficult to make out whether they have an advanced disease or not. But still, at least we tried to weed out the ones which actually did not require immediate attention. But now things have changed. Now we don't have to probably need that. But now we need to demonstrate care probably at the hospital level itself. Thank you, sir. Thank you very much for that. My next question is to Dr. Sri Kumar. He comes from REC Warangal, and he's also the director of iBank. So there are a few things I wanted to ask you, sir. Are there any changes in the practices that you are doing at the hospital to keep the patient safety in mind? And also, is there any help that you need, you seek from the government and other organizations? And especially also keeping the eye donation in mind, the corneal donation in mind. If you can answer that, that will be great. Sir, you need to unmute yourself, sir. We are not able to hear you.
Yeah, thank you everybody for involving me in this panel discussion, especially FICCI and Novartis and other organizations. Thank you so much. Regarding your first question is, sir, well, patient safety is at prime importance as well as the safety of the treating doctor, colleagues, and family. So keeping in mind all these things, really we have changed the protocol pattern of receiving the patient right from the entry of the gate. We are strictly observing and monitoring the SMS activities of the patient. Then we are tracing at the entrance level. We are doing thermal contacting, thermal screening, and contact screening. And we are maintaining sufficient social distance in our all the halls, waiting halls, and examination halls. We are providing sufficient air ventilation across the halls where they are staying. And we are taking care of all the equipment which we come across with the patient's contact, and we are making all the efforts to not to get the disease and virus transmission in our hospital. And we are rescheduling the appointments, though it is very difficult at the government setup, but we are deputing one of the doctors there, and they will discuss with the patient, and they are prioritizing the problems of the patient, and we are postponing the issue, problems which are not on emergent basis. So all these precautions are taking only to give them confidence that we are providing, we are committed to serve them with all the precautions that are required and suggested by the eminent organizations and speakers and WHO. Regarding help that is required, as your second question is concerned, yes, we are working in the government hospital, and as you know, we are serving the poorest of the poor. And during the lockdown, we know even right now, today also, there are a lot of restrictions on the public transport. And the biggest challenge is to reach the unreached people. And a lot of awareness is required even for the people. And only the people who are residing in the town area of Warangal, they are approaching to the hospital. And the people who are away from the Warangal, they are not at all coming. In spite of the efforts, we are putting best efforts in all the public, social media and other channels. And we want support of digitalizing the electronic medical records, especially that are required, especially for the rescheduling and getting feedback and monitoring effectively what is going there inside the hospital and even after leaving the hospital from the patients. And the other biggest challenge, as I was talking about reaching the unreached, we need to strengthen the peripheral units by increasing the infrastructure and the manpower, and we have to we have to propagate what exactly is there at the periphery level so that people will gain some confidence in the public government institutes.
Thank you very much. I think your point on having a EMR and a digital platform, even at the government hospitals, I think it's a very, very extremely valid point, especially now on, that we need to kind of follow up our patients probably telephonically, or we can cut down the number of unnecessary visits to the patient. I think because we need to learn to live with this particular disease. Thank you, sir. Thank you very much. We are actually coming to the end of the panel discussion, running short of time. So I thank all the panelists for their contribution time, for sharing their thoughts and experience. Swati, are we going to move on to the second panel discussion now? Swati?
Yes, Dr. Bhargav, we can move to the next panel discussion.
Yeah.
Thank you.
So
thank you all.
The second panel discussion is on private and public partnership to achieve Vision 2020. We have again very eminent faculty from the south. We have Dr. Anand Kumar, who is associate professor at Sarojini Devi Eye Hospital. He has many publications and has done extensive work on ROP. I definitely want to understand his thoughts on ROP during screening during COVID times and the treatment. He's also a ROP consultant at SDEH. Dr. Rohit Chetty is the vice chairman of Narayanetalia, Bangalore. He is a cornea and refractive surgeon and a clinical and a translational scientist. At Narayanetalia, they train a lot of postgraduates and fellow students, and they also train, especially for ROPs, public sector doctors also. And Dr. Rohit also has more than 200 publications. Dr. Rajanarayan is the director and network head at clinical research at LVPEI. He has numerous publications. He is the honorary secretary of VRSI. So we want to hear from him what VRSI can offer during this time. He's also on the editorial board of Plus One and Journal of Retina and Vitreous. Our next panelist is Dr. C.V. Gopalraju. He's the founder director of Vishaka Eye Hospital and Vishaka Netrajyoti Private Limited. He is the chairman of scientific committee of APOS, and he is a cornea and anti-segment surgeon. So we have a very eminent panel for the second panel discussion, representing both private sector and the public sector. Very eager to hear from all of them, their perspectives actually. And I understand that there will be some kind of a overlap in what we are talking. There may be some kind of a replication, but I think it's good enough because we are trying to hear from everybody's experience. So kindly bear with us. So the present COVID situation has disrupted the services just the way we are discussing. And the Vision 2020 program and under NPCB, the reduction in the avoidable blindness was planned. And now I think that has taken a big backseat. So my first question is to Dr. Rohit Shetty. During this time, how can we ensure good quality care for the patients, of course, and also how to safeguard, at every level, patients and also the staff? And the second question, especially for you, would be what will be the new training and the upgradation of skill levels that can be offered to both private and public sector practitioners?
Thank you, Dr. Bhargav, and thanks Novartis and FICCI for taking this initiative. Most of what I would like to say has already been discussed in the previous speakers. How you would like to keep the area clean. I mean, more conducive for a healthy atmosphere at this point of time. And most important thing is to ensure that patients feel comfortable when they meet you. And if you are not properly well attired, I have realized we've been working from the last week of April to today. The most powerful statement you can do for a patient to meet you and take a date for surgery or come back to you again is how your watchman to chairman are geared up to keep your place healthy and safe. And it's not just the doctors. Many times the doctors are fully geared up and foot to face, and you see the watchman will not be having a mask, and at the gate or nobody to really check. So I think the feel of chairman to watchman being completely geared up is a good sign for the patient to come. So I think that is the most important. You can have your own SOPs. So that is the most important thing. The second question you asked about the training. So we have moved on. See, this is something which was always there, but I think we never realized the potential of an online portal. And we always thought a physical. There's nothing to compete with the physical way of teaching, but we have moved aggressively on a portal of education through the web-based media. And we've created an academy of personalized training, not a webinar, where you can choose what your weekend and you can be mentored in that area. We need more of simulation-based. That is where I think the government and the private sector should join together to build a simulation-based training protocol. We do have, and you are aware of it, of VR Magic, but this is not affordable to every place in the country. Today's cost is around total close to 2 crores. And building a simulation for that much price is just not possible. I think the government, the VRSI, and all the teams should join together to work and build better simulation models which can be affordable to students. Because wherever you go, last 1.5 years, students have not done proper surgeries. This whole year, the final year of all the MS students in this country are coming. This is something which is very important for the government to notice, that we are giving degrees to the entire batch of 2020 without really operating on a single proper case. This is the scary part of it, I think, which has to be really looked into, because I do interview for a lot of fellowship. 2020, most of the students operate in the last year. The final year is when 99% of the students operate and learn the surgical skill. And the final years of 2020 have not operated a single case. So this is scary, and this is something which has to be really taken care in a very aggressive way. This is my answers for both your questions. Thank you,
Yes.
Bharat.
Yeah, thanks, Dr. Rohit. I think those 2 points are extremely valid. The demonstration of care from entrance, front desk up to the doctor, and the lack of training opportunities that happened, especially in the first half of 2020, is somehow has to be compensated in the next coming few months to few years.
Just to complete, Dr. Bhargav, we have opened up most. There's no community services happening even in Karnataka and 90% of India. So virtually there's no training yet.
Yeah. So we have a couple of batches of ophthalmologists who are coming out, maybe at the postgraduate level or at the fellowship level. Probably they have lack of opportunities to train themselves better. I think this is something which the state bodies and the national bodies probably have to look in very, very carefully. I would like to have Dr. Tara Prasad Das' opinion on this, about the lack of opportunities that happened, especially this year. How would we compensate this, sir? I mean, we need competent surgeons coming out.
I was listening very, very intently. On training, very this simulation training for last 10, 12 years actually. Look at those simulator for pilots. Unless you complete these many hours of simulator training, you cannot fly a plane. Just imagine you get into plane and pilot says that welcome to the welcome board. This is my first flight, and how scared you will be. And we do not know how to compensate for, because medicine cannot be taught by from distance all the time. Theory can be taught, but not the practical part. We do not have anything right now which you can do. And right now, those who are interested, Orbis Cyber Site is giving a 5 days, 5:30 to 7:30 seminar on simulator training from nurses to optometrists to doctors. But I agree that they're all expensive. Some are cheap, do not to offer immediately. But as you're opening up, example, LV Prasad, you opened our cataract surgical training middle of last month. That you cannot wait, because you cannot afford our doctors to be unsafe, because whom we train, not that all are our employee, but they go to the country, they operate in India, and then India should be not unsafe. I do not know the answer, honestly speaking. Simulator training also has also their own caveats, because this cannot be done everything. Because simulator training requires a 4D, that means you feel sensation. Example, VR Magic. I have VR Magic actually. VR Magic only does some gimmicks. You cannot feel it. Only can see it. So that's not enough. We must know how to feel it. So most of the they are a little better, but they are very expensive. I have no answer to this at all, but I'm wishing that things will change and we'll able to see patients again like we used to do before. Of course, with their personal protection devices, and then train people to be safe. I have no answer to this question. I'm sorry, I'm not able to answer you at all, Bhargavji.
Right, so I think this is a important a problem that probably we will face in the next coming few years. Maybe we need more training centers who can take up the fresh graduates and give them specific training in the areas that they feel they lack knowledge or skill in. So maybe that Raj also can.
National education policy actually allows us to do many things like US and Europe are doing before, but that doesn't cover, unfortunately, medical. To be in touch with a person, otherwise you can't do certain things. And but important also, the training is understand that unless they are properly trained and they should not be actually working. They should, so their graduation time should increase from 3 years to maybe 5 years, 6 years, because they'll be unsafe. Unsafe to their own family, unsafe to the whole country.
True. So I request Raja to share his thoughts on the present scenario, that the things that we are discussing. What are the initiative VRSI can take, and what are the patient support programs that we can do? How we can use technology to leverage the limited opportunities for the patients and also for the training. Dr. Raja?
Yes, so Bhargav, thanks for the very important question that you have asked. I think the point which Dr. Rohit Shetty and Dr. Das have touched, I think all of us may have some comments. I'd like to start off from there about training. So while so far we have focused a lot on numbers, every resident or fellow should be doing so many numbers. Up to a level are important, but beyond that, a structured training is more important than if someone says I've done 100 cataracts. So if you need a proper coach, which means a training of trainers, it's not enough to have and say I have 50 faculty in my medical college or institute. You should be able to see how many of them are able to teach or coach a simple cataract surgery. Pardon me if I'm taking an example of cricket right now instead of cataract surgery. But if a player has to start hitting sixes, you cannot have just another player and say, just swing the bat and it should go for a six. You have to be able to teach each and every step of how to visualize the ball, what speed the bowler is giving, where it is pitching, what is the angle of your swing, where is your left shoulder, elbow, all these things while you are doing, let's say, a cataract surgery, making a tunnel, assessing a patient, whether it is a deep set eye or not. All these things should be able to be in a structured manner that coach. What you say as a training program, it's actually a coach, not just someone who has done 100 or 1,000 cataract surgeries being able to tell, but they should be able to tell where is the mistake, and if you correct this mistake, you will be able to do it the right way. So while stimulators are important at some stage, technology we should be able to use. They are very expensive at this point of time, as has been already mentioned. But slowly we should concentrate more on human resource itself doing the training in a structured way. One good case being taught is equivalent to another 15-20 being done by random error. In terms of VRSI's initiatives, we have obviously with AIOS we have published guidelines for the healthcare providers how to other than the general hospital premises of reducing the risk of infection and PPE. We have also given guidelines for injections, surgeries, lasers, how to clean the equipment, laser lenses. All those things have been adequately published in the IJO. In terms of public awareness, we have partnered with Dr. Ratna Devi's organization also. We have spoken in multiple platforms about improving patients' confidence. And we have also partnered with the RSSDI, which is the Diabetes Society of India. We are doing now joint campaigns on FM radio for increasing the awareness of diabetic retinopathy. With FICCI, in terms of IRDA, we have now got insurance coverage for intravitreal injections, which has taken more than 4 years actually of work together to convince them. Again, it is good that they are covering all injections, but I just want to raise this point with FICCI because this platform is about FICCI. I really have to say that while a lot of things are being now brought under coverage, the insurance premium which I'm seeing being increased, whether it's for COVID or any other reason, it will make some people drop out. And the more people drop out, the more people will fall into poverty. And the only way to stop reducing the increase in premium when you bring in more diseases and procedures under coverage is to increase the pool of healthy people among the policy holders. The healthy people will, once they share the risk, the premium increment will not be much more. But what I am seeing now is that the healthy population being brought under insurance coverage is less, while we are increasing the procedures being brought under coverage, the premiums are increasing. My parents' premiums have increased by 75% in just 1 year. Fortunately, they will be in a position to absorb this. I'm not sure how many people will be able to absorb this shock, and that's of no use having insurance when people will start dropping out. So that is something I want to FICCI to take note of.
Yeah, yeah. I think that's a very good thought. I think influencing the insurance agencies to consider all these factors will be good. Do you think insurance companies should start looking at covering the PPEs for routine surgeries, and are they already doing that? Are you aware of any insurance company who are taking these initiatives?
Yes, as per my interaction with them, they are already covering it. Whenever patients are undergoing surgery, they are covering the PPE equipment cost in the hospital bill.
Right. So thanks, Raja. My next question is to Dr. Gopal Raju. I want to hear his views on how do we start our outreach activity. How do we make the eye camps start again, and then once we start, how do we make it very, very safe for both the staff and for the public?
Thank you, Dr. Srivastava, for excellent moderation of the program. First, I would like to thank FICCI, Novartis for organizing this program. Coming to my view, first I'll briefly tell you about our state experience of how the medical care was monitored during this time. So if you remember way back in 2006, Andhra, though at that time it was a combined state, it is the torchbearer for the introduction of the healthcare insurance scheme for the poor. I think that was one of the greatest innovation and one of the excellent program for the poor people to avail the facilities of both the government as well as the private healthcare organizations. That program was a huge success, and we have learned a lot of lessons from that program. And the main success behind that program was entirely monitored by the separate healthcare trust, which was headed by the cadre of the IAS. So it was very well managed. And the another main reason for the success of that program was almost 90% of the people below poverty line were covered under that scheme. So they can easily avail all the latest treatment facilities and the modalities. So then another greatest thing is majority of the private organizations, corporate hospitals, and including the government hospitals were part of that program. So just because of that program, both the public and private partnership has automatically it's involved. But unfortunately, the subsequent governments have run it very successfully, and that experience and then that successful running of the program has really become very handy during this COVID times. So the present government, which was very serious about the healthcare sector services, and under the name of the YSR, the Arogyasri Trust, and in that, eye has become the main focus for them. They have started the program as the continuable program. They have screened all the school children, and then they started the program for the aged population. So unfortunately, by that time, the COVID has started, but that experience has really helped the government, and because already the majority of the private practitioners, the NGOs, and then the corporate hospitals, and then the government hospitals were a part of that program. So during that pandemic, they activated the telemedicine program, and then they have really done a great service, and then they have catered to all the emergencies during the COVID time. So another reason for the success of this program is, like the other time the Hemant Murthy was mentioning, the payments were less. But in this program, the payments were reasonably good.
So because of that, the private the organizations also could maintain a reasonably good standards, and then we can continue that program. So during this pandemic, through telemedicine and the emergency, through that the ROPC program, most of our hospitals were serving the emergencies and doing the services. Subsequently, they allowed the walk-ins during this pandemic. So they allowed all the people who are having the healthcare cards, so they can come to the hospital. And the hospitals will honor that as a program instead of going to the villages and then conducting the camps. So we can continue the program. Those whoever can reach the hospital, still they can avail the facility. But coming to your next question, how best we can restart the outreach programs. The one way is we have taken the help of the service organizations like the Lions, then Rotary, and then Satsai organizations. They have an excellent voluntary network throughout the villages. So the volunteers in that village, they can identify the needy people or the people who really requires an early treatment. We have activated all those voluntary organizations which were earlier already doing the camps. We told them, we gave them instructions that right now the government is allowing the walk-ins. Camps is still not a safe time to reactivate it. You bring all the necessary people whom you find they are really required. You please bring them to the base hospital. We are here to serve you and continue the same thing. And then maybe in near future, I think all this pandemic, typically a psychologist says, first is the shock, second is the fear, and the third is the acceptance. Then now I think we have all reached this stage. Now we are all now ready to live with this. And then we have designed this. I think we said shortly we can reactivate the camps, but with all the precautions like restrict the numbers, and then pre-screening by the pre-visit the people, volunteers. They can screen, and then needy people can be gathered, and where our teams can go there and then screen the people and bring the people in a limited number with maintaining all these social distance. I think next stage, first stage is allowing the walk-ins, second stage is screening by the local volunteers, third stage is keeping them gathered as limited number and then go there and attend. And then next, as it continues for some more time, because during this COVID time, we have seen a lot of the cataracts are getting mature. Now, if you see on an OPD, almost 50-60% of our surgical volume, almost the cases are total cataracts. So that shows definitely there was some delay in our the healthcare services delivery. Once we will reactivate all these types, then maybe after the 6 months, maybe we all can come to the old modalities that we can serve. And that is, I think, that is how we are looking into the program. Thank you, Barbara.
Yeah, right, sir. Thank you. Thank you very much. My next question is to Dr. Anand Kumar. So again, I have two questions for you. One is that out of your experience from Sarojini, do you think that the public hospitals need some kind of a support in clearing the backlog of cataracts or any other kind of a surgery from empaneled private hospitals? Or do you think the manpower probably should be good enough for us to deal with this in a couple of months? That is the first question. The next question is about the ROP screening. Did the ROP screening become a big challenge during this lockdown, or it went on probably as it was going before? And the delivery of laser and care to these, was there any challenge in ROP care?
Thank you, sir. I am audible, sir. Hello, I am audible.
I hear you. Please go ahead.
Sir, good evening, sir. Thank you to Novartis India and Vision 2020 and FICCI giving opportunity to the government doctors. So I am very thankful. For first question, sir, the Vision 2020 goal after this pandemic is to treat the problems related eye who are waiting for quite long time, as most of the treatments are planned and they can wait. The patient flow is rising day by day after unlock 5, and we can expect a huge rise in numbers. So we need to get ready for that. In my view, the government should take a step forward to make the empaneled private hospitals on area-wise basis a target for sharing the patient flow from the government hospitals. Anyway, the ROGC empaneled hospitals are playing their role in the treatment, which may not be sufficient for the predicted patient inflow. Many more hospitals are awaiting for the empanelment, which are to be done on immediate basis for the distribution of patients who work more excitingly than previously empaneled ones. There should be a short-term agreement between the government and private hospitals for at least a year for smooth flow of the patient to retain their vision, which include general OPD and surgery, which the government can owe some benefits to them based on their area they are located. By this, there can be decrease in patient flow. The government hospitals and the patients can avail the facility in their nearby location by getting rid of travel, which also be a step to control the COVID-19. Government should advertise about the services at the empaneled private hospitals and centers in print, electronic media for general public to know about the places of availability. Information centers like PSC, CSC, and urban centers, Vaidyavidha and Prasad, and nearest the available hospital and service over. And government should make the private hospital to conduct free eye camps in rural areas by maintaining COVID-19 norms for decreasing the general patient flow to the government hospital in collaboration with TSRTC. It is also facing a huge loss. We can set up a small clinic in RTC bus and conduct camps in villages on daily basis. The surgery patient can be shifted to the government or empaneled hospital for treatment. A government doctor, any official will be heading a group for hospital camps for the smooth flow. Government can take the initiative in collaboration with private hospitals for eye retrieval, which was moving on a slow pace from the start of this COVID-19. Likewise, the eye donation advertisement can also be done, sir. That is the main thing, sir. But the second answer for this ROP, we are doing the ROP screening in Sarojini Devi Eye Hospital and Nilofer, sir. In every Thursday, we'll go to the Nilofer from a team. A team will go from Sarojini Hospital to the Nilofer. Every Thursday, we'll screen 60 to 70 neonates. Among that, during this pandemic, we are continuing, we are not stopping on a rotation based. Every week, we had a group, 2 to 3 groups. Like that, we divided and we are doing the screening. Meanwhile, during this lockdown period, we got almost 10 to 15 ROP, severe ROP babies. And we went there to the Nilofer. Actually, we want to give some anti-VEGF injections because the babies have stage 3 and stage 4 problems. So want to do laser, but babies are not at a good condition. Baby is going to the apnea for laser. So we planned for anti-VEGF injections. For shifting the babies from the Nilofer to Sarojini Hospital, it is difficulty. We take an idea from the pediatrician. They didn't allow it to make a transport because baby will go to the apnea and maybe some problem. Then I took a permission from my superintendent for giving the injection into the NICU only. My superintendent gave the permission and we went there with my team and gave the anti-VEGF injection. Luckily, the baby survived and the ROP also luckily decreased. The baby got good weight. Another risk, sir, during laser, we got some problems due to some these coronavirus spreading during laser. So we did by taking our precautions, we did the lasers and we did some surgeries also. Meanwhile, through this discussion, I want to share that what my experience to you. Please, we want some benefits or some support to the government institutes. We are lacking the instrumentation wise for doing the ROP surgeries. We don't have good posterior segment microscope for doing the ROP surgeries. We are referring to the higher institutes, means like LV Prasad. I trained from LVP, but I am referring. I trained, but I am referring because of lack of posterior segment microscope. And meanwhile, proper instrumentation, all those things. So we faced so many problems during the lockdown period, but we did, sir. We never stopped the screening, even though we are taking our precautions with our team. From March 30th till today, we screened almost 400 ROPs, and we did laser 4 to 5 cases, and we injected anti-VEGF for 3 to 4 babies, which are in serious conditions, sir.
Private hospitals, thought process and increasing the infrastructure in these kind of government facilities will also reduce the referral burden. I think that those points are extremely well taken. So I think we are
Thank you, sir.
we're almost reaching 45. So I thank all the panelists for sharing their wonderful thoughts and their experience actually. Dr. Raju, Dr. Anand, Dr. Raja, Dr. Rohit, all had extreme, very valid points to make. So, so Dr. Das, can we have one concluding remark from you, sir?
Let me congratulate idea and very important, and then prints all most of the messages in newspapers. Very important, as was pointed in the beginning, that many freestanding eye hospitals are not really COVID infected, so many patients can come whether Sarojini Hospital in Hyderabad or LV Prasad, and not that other multi-specialty hospitals are not taking care, but because of them only we are safer. At the same time, we should keep our technology front before us, so that you can reach the patients not necessarily in a home, but even necessarily not bringing to hospital again and again, because that itself very important in a populous country like India. When it comes to healthcare, two things that I observe in my 40 years of ophthalmology is that one, we are less adapt to new technique and technology like we adapt to new mobile and cars. And the two, Indians by nature want to spend less on health than on a pizza and burger. It might hurt some people. Even my daughter is very fond of pizza and burger, though. I think that also requires a mindset change. That doesn't matter how much insurance pays, insurance will not able to pay 100% for everybody. When you talk about the universal health coverage and talk about the catastrophic reduction in health expenses, it talks about that you should not spend more than 10% of your household, more than 10% household expenses for healthcare. That's all it is. Not that whether it is a most rich person in India or the poorest person in somewhere else will not able to spend much. So like the insurance, supposing we create a model of cross subsidy that rich, like Mohandas Karamchand Gandhi told that this should be trustee of the poor, then every rich person can be also handhold some another poor person to do certain things. That requires a huge mind change. And unless that also happens, we should not wake up an Indian because there's a Kargil war. No, we should be Indian every time. While insurance doing what it can do, hospital doing what they can do, and we should do it. Finally, the blur between so-called government and private should go away completely. In my region, South I work, there is only one country, Bhutan, where healthcare is completely free. In Maldives, an organization called Asanda takes care of people. The Maldivians go outside the country for the eye care, and they say that they go for more for pleasure than for actual technology. There are countries like Timor, the poorest country, most emerging economic country in the world today, is also trying to offer. Government can do as much as possible. In a country like India, Indonesia, Bangladesh, Nepal, Thailand, unless private people also harmoniously join hands to the government and government accept them. Unfortunately, India government doesn't accept it. In our region of 11 countries, Southeast Asia, the country has done fantastically well in promoting the government-private cooperation in Nepal. Nepal is the only country, unlike hating those optometrists and vision technicians, allowed it. Healthcare there is high, even though they're still poor. the CSR and the CSC carotid surgical rates are carotid surgical cover high or equal to Gujarat and India average. You must learn this lesson from different countries. I in my own estimation, primary healthcare is fantastic in Sri Lanka and but is fantastic in Nepal. So if those examples are learned and we assimilate those examples, then only you can go forward. In a country 1.34 billion people, you cannot go forward. Unfortunately, government suspect private and private think government is stupid. And both are not correct. We learn how to do this. I don't think we can do it. In addition to insurance, the people who are rich and affordable can also contribute X amount their might to the care of the poor, so that everybody, no one is left behind. Philosophy. I don't happen.
Thank you, sir. Thanks for those concluding remarks. So, Swati, I think we did discuss a lot of challenges and we discussed some possible solutions, and I think we have all had something to learn at the end. Over to you.
True. Very much true, Dr. Bhargav, and quite agree with you. And thank you for the great discussion. Actually, both panel discussions were quite informative, and we had such great panelists. So thank you to all panelists as well. Moving on, we move to our next talk on insurance and eye care. It will be delivered by Shri Aries Rizvi, who is Senior Vice President and Health Risk Consulting Leader at Anvity. He leads the health promotion team for Anvity with over 20 years of multi-sectoral experience, including setting up of corporate wellness vertical for India's largest national hospital chain and benefits broking. Aries has done his BA honors from Huddleston Field University, United Kingdom, and AMP from IIM Bangalore. He also holds a certificate in integrative workplace wellness from T.H. Chan School of Public Health, Harvard University. Over to you, Mr. Rizvi.
Hi, good evening, everybody. I had a hard stop at 5 o'clock, so what I'm going to do is try my best to crunch my 10 minutes into maybe a 3, 4, 5 minute quick overview. I think it was a fascinating discussion. It has been a fascinating discussion so far. A lot to learn from all the esteemed panelists who've spoken before me. And a big thank you to FICCI and Novartis to this very pertinent discussion today. So very quickly speaking, I'm going to pick a few things that were discussed, just before I got my turn to speak. And I think Dr. Raja made an important note of how insurance has sort of evolved after a long, hard struggle to include some of the advanced therapies that are now payable. Of course, the solutions are not very simple, but yes, a small beginning has been made there. I think Dr. Das, with his considerable experience, also, very rightly, sort of give example of Mahatma Gandhi's, philosophy that there's enough for everyone's need, not everyone's greed, and therefore maybe the rich should try and discount some of the or cross-subsidize the funding for the bottom of the pyramid population, and I think that's a very noble thought. Now, from the eyes of an underwriter, from the eyes of an insurance company. And if I were to juxtapose this against, how a clinician or a health establishment, and I will sort of bundle doctors, physicians, hospital owners, and operators into a so-called provider landscape, and I would perhaps reflect philosophy coming from there to how an insurance organization sees risk. How does it price risk? Dr. Raja actually did point out a very interesting and an unfortunate truth and reality about the increasing cost of insurance premiums year on year. Now, there is no easy solution to that, and there is no easy answer to that as well. Please bear in mind that the risk pricing or the risk premium pricing is a direct of the inputs that go into it. And what are those inputs that go into it? The inputs primarily is the cost of healthcare, which is the amount of money that a physician or the healthcare establishment charges a patient for a certain procedure, right? Of course, the provider landscape has the right reasons. There is increase in technology. There is increase in now fixed costs with all the PPEs, etc., and disinfecting protocols that are in place, leading to higher costs. And of course, somebody has to pay for it, and the patient ends up paying for it, and therefore the overall of healthcare in India is perhaps one of the highest in the world. And that is, of course, reflected in the high insurance premium. So that is one aspect of risk pricing. The other aspect of risk pricing is, as Dr. Raja very aptly pointed out, is the extremely low insurance penetration of in India. Overall, I think our insurance penetration of all kinds of insurances, and I'm not just talking about health insurance, I'm talking about all kinds of insurances, is slightly under 4%, right? I think India ranks 41st in the overall sort of GDP's contribution to insurance premium. So that's very, very low. And out of that 4%, close to about 3% is life insurance, right? So all of us have been used to buying life insurance as soon as we, had a birth in the family, or the daughter was of a marriageable age, or we started working, etc. So those are historical, cultural constructs there. Only 1% is general insurance, of which health constitutes only, I think, about 0.23%. So this is the extent of low insurance penetration. Now, and premiums, of course, are a function of it, but that may not be entirely true. The main reasons behind a low penetration of insurance is also lack of education. And I think industry forums like these would go a long way in making sure that the message of planning for risk, like you plan for investments, you ought to plan for risk, is imbibed fairly early on in every professional, in every individual, in every citizen. Health is going to continue to get more and more expensive. We know that a significant portion, so while the bottom of the pyramid and below poverty line, there
Bhargav, I think we lost him.
Yeah, I think he has got disconnected. So maybe he's just connecting back again. We'll give it a moment.
Yeah, I think there is
Till we move further.
must be an internet problem.
Yes.
That maybe we should have internet insurance also. You are the insurance expert.
That is true.
I was about to say that a 70% increase in insurance cost, which is not very correct.
No, sir. Actually, it is correct if the person happens to be over one particular age, and family floater kind of things are being considered. I also noticed that suddenly the insurance premium went up for my family members. May not be 70%, but it did go up.
What age you are today, you will certainly become 100 one day, right?
True.
So,
I think he has joined back, Mr. Rizvi.
Yes, I am there.
Yes, please. You may continue. Thank you.
Yeah. Did I drop off at any point in time?
Yes, so you had got disconnected in between. We weren't able to hear you. So now we can very much hear you.
Okay, so you'll have to help me at what point did I get drop off?
So I think
Talking about
Never mind. So I was basically referring to the fact that insurance premium and pricing is basically an output. The input that goes into it is, of course, the rising medical inflation, the cost of healthcare that is being provided, the added cost of PPEs, etc. That are coming in, newer technologies. So that is one aspect of why the medical inflation is going up year on year, and that is having an effect on the insurance premiums. The other is, of course, the low base that Dr. Raja mentioned. Uh, uh, I don't know a lot about the rich discounting the poor, but definitely in insurance parlance, it is the fortunate many who need to discount for the unfortunate few. And that is the underlying philosophy of insurance, that you spread the risk far and beyond, have multiple number of people who are supposedly healthy, who then pay for the unfortunate, unhealthy, who would require that kind of support. And that is the basic premise of risk pooling. Then I touched upon how perhaps different stakeholders can work towards increasing that base. I think today insurance companies are investing significant amount of money and capital into their marketing campaign, advertising, etc. So that is happening there. Government is setting up its own initiatives, which are, we've seen that over the last 20 odd years, the government has turned from a provider to a payer, and therefore is riding on insurance schemes to bring healthcare to its citizens. So that is happening at a certain level as well. But I think it also is incumbent on bodies like us to stress upon the fact that insurance as a risk tool is perhaps the most important investment that an individual can make. I think the doctors and the clinicians should convey this message not just to their patients but to their dependents as well, and basically just keep amplifying this message as soon as as far and wide as possible, because if the coverages and the base goes up, obviously the premiums will come down. Yeah, medical inflation is perhaps something outside of our control, but yes, if I guess best practices are followed in terms of cost control while ensuring, excellent patient outcomes. Nothing like it. I think some amount of cost consciousness in medical establishments also, would go a long way in ensuring that we try and tame the medical inflation. I could have gone on and on because insurance is a large subject, but I'm mindful of the time. I think we've already busted the deadline. So perhaps I would, request some other opportunity where we could, do justice around how insurance and insurance could help in addressing the funding gap that exists currently at this point in time. But we have to be sensitive that yes, the regulator has gone ahead and made certain changes for the better. Is that enough? Perhaps not so. But at least directionally, we know that we are in walking towards the right direction. So, thank you so much for this opportunity, and it has been a great learning. So, thank you so much, Vicky. Thank you so much, Novartis, for this lovely opportunity to share very briefly on some of my viewpoints here.
thank you, Mr. Rizvi, and I hope that we connect again and we can take this discussion forward. So with this, we are coming towards the end of this webinar, and I would like to thank each and every one of you for joining us and your perspectives and thoughts on this very important area, which seems to be right now neglected in the wake of COVID-19. And we thought that through this webinar, we could throw some light or spotlight on this. I would like to thank Dr. Rajni for joining us today and sharing her perspectives on what initiatives are being taken by Government of Karnataka towards the visually impaired. I would also like to thank Novartis India, Vision 2020, IAPB, VRSI for their kind support in organizing these webinars. I would also like to thank Dr. Tara Prasad Das, Chanakya Mishra ji from Novartis, our moderator, Dr. Bhargav Natesh. Quite interesting panel discussion, Dr. Natesh, and thank you for your time and participation. And also Mr. Rizvi. And not to forget our very eminent and expert panelists, Dr. Virajalingam, Dr. Shri Kumar, Dr. Ratna Devi, Dr. Hemant Murthy, Dr. Prashant Garg, Dr. Anand Kumar, Dr. Rohit Shetty, and Dr. Raju Narayanan, and Dr. C.D. Gopal Rajuji. Thank you so much. Thank you so much for joining us today.
Thank you.
Thank you for bringing us all together to one platform, Swatiji. Have a nice evening.
Thank you. Thank you. Thank you,
you.
everyone. And nice discussion. Thank you.
Thank you, everyone.
I leave now.
Thank you. Thank you, everyone.
Sure, sir. Thank you.